Concept Medical for inviting all the stalwarts of cardiology for this particular meeting. And without any delay, I think I would like to invite Dr. Sameer Dani sir, who is a very well-known, renowned cardiologist from Ahmedabad city. He is a national repute cardiologist, and he is a teacher, and we have a very high regards for sir. So he's going to be the chairperson for this event, and sir is a director of Apollo Heart Institute and Apollo CVHF Heart Institute. Along with him, Dr. Prathap Kumar sir is there. Dr. Prathap Kumar, he himself is a very senior cardiologist practicing since last more than 20 years in Thiruvananthapuram, and is the founder member of IJCTO. We all know that that IJCTO conference was being started with Prathap Kumar sir. So I'm extremely glad to have Prathap Kumar sir and Sameer sir for this particular first series of masterclass, where the topic is challenging in PCI. And with that, I would also like to invite my panelist, Dr. Anand Shukla, who is a senior cardiologist, and Dr. Tarun Madan, who is again a member of Krish Heart and a senior cardiologist from Ahmedabad. So with that, let me invite Dr. Kamal Sharma and over to Dr. Sameer sir and Prathap Kumar sir.
Hi, Prathap, I think you begin. Invite the speakers. And
you can start the proceedings, Sameer.
Yeah. I mean, we'll invite Dr. Kamal Sharma, a brilliant, forever young cardiologist from the city of Ahmedabad. We will ask him to present the Enable registry data. Over to you, Dr. Kamal Sharma.
Hi, good evening, everyone. I hope my slides are visible.
Yeah, it is visible.
Okay. So, thank you for giving this opportunity to me, to all the co-authors. And I must say, I was just one of the authors, and you all on the panel have been the guiding force and have been the people who have been contributing to this registry in a big way. So what I'm going to talk about is the paper that we published. It's a 2-year safety efficacy of indigenous abluminally sirolimus eluting stent, which is abluminous. We looked at whether it differs, the outcomes are different in diabetic versus non-diabetic. And this is the link for that article, which is now published in an international journal. So before I go and present the data, let me just take you back to the Abluminous DES platform, which is basically a cobalt chromium stent system designed for diabetic and CE approved now for the diabetic and acute MI indication. It's designed to treat diabetic patient with the Envision technology, as it is called by the company. We understand that the current limitation of the DES include delayed vessel healing due to slow endothelialization and high inflammatory response, which in turn can lead not only to in-stent restenosis but also stent thrombosis. And these all, of course, are reflected into the major adverse cardiac events, which include cardiovascular death, T-trap, the myocardial infarction of the target vessel, or a re-PCI, as we call as TLR, for the same. So the current DES, the way currently the Abluminous DES platform comes with certain DES technical specifications, and also we'll compare it with the currently available specifications as compared to Abluminous DES. You can see that the crimping is done after coating in the other DES that are available. So it may get affected as crimping is done under the process after getting the coating, while the Abluminous DES gets coated after it is crimped. So this allows the drug to be uniformly coating the abluminal surface area prior to the mounting on the balloon. The other important aspect is the dual side coating that goes into the pre-crimped other drug-eluting stents. And this can actually deter the re-endothelialization on the luminal aspect, because the drug inhibits the same to the proliferation of the normal endothelial cells inside the lumen, while the abluminous has abluminal coating, which actually causes faster re-endothelialization in the adluminal aspect, while the abluminal aspect is the one which is inhibited by the drug, and hence the ISR is prevented. Focal restenosis is caused by almost 14 to 16% metal to artery ratio because of inappropriate drug exposure, which is again addressed by this technology, because both the stent as well as the exposed part of the balloon are coated with the increase in the surface area, and hence decreases the drug delivery, which can actually prevent these kind of restenosis. Edge restenosis, again, which is very often found with the other DES, is because the balloon is not coated in here, because the balloon overhang of the stent is also coated with the drug, and hence the edge restenosis, because of the 0.5 millimeter overhang from the stent, is coated, and hence it's also is claimed to be prevented by the theoretical aspects and the advantages that the stents carry over. So the technical specification for the drug, as we all know, it's a sirolimus drug with 0.7 microgram per millimeter square, which is customized with a biodegradable polymer matrix, cobalt chromium alloy L605 with stress thickness of 73 microns, with 80 micron strut width at the hinge and 120 at the strut, with the average recoil being less than 5% and average foreshortening less than 1%, though it's claimed to have zero foreshortening design, but no metal, I would believe, if it's undersized or underexpanded, would end up with 0% of foreshortening. A drug delivery system is the RX delivery system with nominal pressure of 8 bar, RBP of 14 bars, compatible to O14, guiding catheter 5 French, diameter ranging from 2.25 to 4, and stent length ranging from 8 to 40 millimeter, with a crossing profile of 038 with an entry profile 016. So this is like matching the class, all the strategies, all the other competitors that exist, and a lot of the other parameters are much better than that. Especially the strut thickness and the abluminal technology that I just touched upon. Now, coming to the data that was collected for the Enable registry, this paper was published in the Journal of Cardiovascular and Thoracic Research, which is basically an Iranian journal from Tabriz University. It's a PubMed Index High Impact Factor journal, which is peer-reviewed, open access, and this was published recently in the current edition. It's now available. The other authors were the respected chairpersons of the session, Dr. Dani, Dr. Prathap Kumar, Dr. Devang Desai, Dr. Neerav Bhalani, Dr. Apurva Savda, and Dr. Rutvik Trivedi, and of course all the centers, which were more than 31, that contributed to the registry data, as Dr. Jay himself was part of the same. The objective was to evaluate safety, efficacy of abluminous DES in all comer population with minimal exclusion criteria. And as I mentioned, 31 centers with ongoing open registry for all comers in a prospective multicentric fashion was done. This included ambulatory visits or telephonic contact, which is at 1 month, 9 month, 1 year, 2 year, and this has been followed up up to the 5 years now. The primary endpoint was defined as MACE, which was a composite of cardiac death, target vessel revascularization, or target lesion or target vessel revasc at 1 year follow-up, and then it was followed up at 2 years. The secondary endpoint included stent thrombosis as per the ARC definition at all point of times, and MACE was hence assessed at 2 years and then up to 3 years, and then it was continued up to 5 years. So we have published the 2-year data, and Enable registry is still ongoing, and this actually included all the aspects, not just the diabetic and non-diabetic, but we have just presented one aspect of this, which is diabetic and non-diabetic, and I take the permission from the Concept Medical that we are actually in the process of drafting short versus long and acute coronary versus non-acute coronary data as well. So these were the baseline characteristics we have looked into here, primarily diabetic versus non-diabetic. These were 2,500 patients in all. 2 patients were lost to follow-up who could not be contacted either, even telephonically, also to even their relatives. They were excluded from the follow-up. You can see that 859 patients were diabetic and non-diabetic were 1641. The baseline characteristics were pretty much matching. The male predominance was found again in the non-diabetic subset. Hypertensives again were more in diabetic subgroup. Tobacco chewer were matched. Dyslipidemia again because of diabetic status. These patients were more likely to have it. Renal disorders again because of diabetes. As I said, these were not cohort matched. This is just the analysis how the patients were looked at into diabetic versus non-diabetic subset. These were also the patients who had higher prior CABGs or prior PCI, almost twice as compared to non-diabetic subgroup, and they also had a higher LV dysfunction with a baseline EF of 39.12 plus minus 12.22% as compared to 47 plus 5.2 plus minus 8.86%. Now, why I'm mentioning these differences, because this also translated into the outcomes. When you had a sicker subgroup of patients being enrolled in the diabetic subset as compared to non-diabetic subset, this was also reflected in the cardiovascular into the CV mortality as compared to those who were non-diabetics. You can see that the prior MI was higher actually in non-diabetics. ACS was again higher in non-diabetics. STMIs were also higher in non-diabetics. The rest of the parameters were pretty much matched, and stable angina was more likely in patients with diabetes. You can see the number of vessels treated. You can see the most of the diabetics required more vessels to be treated, which is again expected. Even the stent length, there was a tendency, but you can see the mean difference was not very different. Neither was the difference between the mean diameter late loss. Mean diameter stenosis is as per the lesion as defined by QCA or reported by the cardiologist putting the stent. Pre-dilatation, 1 balloon, 2 balloon, 3 balloon. Again, there was no difference between the two groups. Neither was the stent length or the lesion diameter or the number of implants as which were higher in diabetics as was anticipated in these patients. Stent diameter, you can see there was statistically significant. Diabetic patients had a smaller mean diameter for the stent deployed, and the small vessel disease again was more preponderant in diabetic subgroup, or amounting to 62%, defined as less than or equal to 2.5 millimeters. Patients with long lesion, defined by more than 20 millimeter length in lesion, was not equally matched. As I said, because of the length of the stent, this might have been different, but number of stents deployed were more. Long lesions again was matched. Vein graft interventions were higher in diabetics, and mean lesion length in the vein graft was also higher in diabetics as compared to non-diabetics. These are the cumulative results at 1 year. When we look at the loss to follow-up at 1 year, there were 7. When you look at 3-point MACE, again, there was a statistically significant difference between diabetic versus non-diabetic. And these were primarily reflected by cardiac death. As you can see, the cumulative MACE of 3-point is higher in diabetics, but amongst the 3 individual endpoints, target vessel revasc or target vessel MIs were almost the same in diabetic versus non-diabetic. However, CV death cardiac deaths were higher in diabetics, and this was driving the 3-point MACE to be higher in diabetics. When you compare stent thrombosis, there were 14 events equally matched in the two groups, and there was no statistical difference between the diabetic and non-diabetic arm. Now, this goes on to show that cardiac death primarily being higher in diabetics, which is expected even otherwise, was driving the 3-point MACE. And as I showed in the baseline characteristics slides, the patients with diabetes were actually having all the characteristics that were worse, like baseline LV dysfunction, baseline prior revasc or baseline multivessel disease. And these were responsible primarily for a worse outcome, as was noted later on, which we can ascribe to. Again, the 2-year follow-up data, when you can see there were 7 loss to follow-up. And again, this was higher in diabetic subgroup, and this also could have contributed to some amount of biasness that we may have with the interpretation of the data. But the cardiovascular death continued to be higher in diabetics. TVMI or TLR were not statistically different. Stent thrombosis again was not very different between diabetics and non-diabetics. So this is one of the kind of first ever study with this kind of technology which has been published in an international PubMed index, reputed, peer-reviewed, open access journal with an high impact factor, which shows that the abeluminous has been a safe and effective DES with good outcomes both in diabetics and non-diabetics, with a very low 3-point MACE in the cohort. 3-point MACE again in diabetics was higher and primarily was driven by the CV events in terms of CV mortality, though the target vessel revasc or target lesion revasc or target vessel MIs were similar between both the arms. So this is how the article is doing. Actually, this is almost a week back, and you can see that almost 69 times this article has been downloaded, and a lot of that has come from US beyond India, that their people are showing this in this article from the Tumors Press in the journal, and the abstract has been viewed by almost 300 times now. And then you can see that it is e-published only in 19th May in 2021, and it required 4 months of correspondence before the article could get through. So thank you very much. Thank you for patient hearing, and I hand over the session to the chair. Thank you very much.
Thank you, Kamal. We all knew kind of beforehand that this stent has the potential, and in the clinical trials, we have found that it really performs very well and has a very high safety profile. What's up your comments?
Actually, this stent, one more advantage of this stent is basically it is much more trackable than many stents. So when you have a difficulty in taking a tough lesions, I think we prefer to take abluminous as the choice compared to any other stent. The safety profile, as Sameer mentioned, we all know that, and the people sitting here, most of the people are actually part of the trial, so they know the safety profile as well as the outcome very clearly.
Anand is here. Tarun, you can tell about your experience with the stent.
Sir, majority of the times whenever I've done it with Jay. Personally, I do not have any first-hand experience of this stent, but I think the trackability and the end results are comparable to FDA stents.
The premise of this stent has been, the technology where it differs, which was kind of a hindsight, because bioabsorbable polymer, the coating of the crimped stent, coating of the balloon, as well as the stent, these were kind of characteristics or technical parameters which we kind of realized later on that could be in fact more beneficial. The abluminal coating, of course, was a key thing. This was probably the first stent ever to get the abluminal coating.
True, sir.
Right. Any other comments or questions, Jay, Rutvik?
I'm having the same experience as Sameer sir or Kamal bhai is having, or maybe Rutvik is having, because I've used it in almost all complex category of cardiac intervention, like from primary angioplasty to like a multi-vessel or a long lesions, even in a I'm going to show that case in an anomalous vessel. Even if it is a tortuous and a little abnormal origin, the trackability of this stent is really remarkable. And as sir has already told that it has got a very good abluminal coating. The mechanism of this particular stent was being complete match, or a somewhat match with even a Boston Synergy stent, which is having the same sort of quality as that of abluminous. But as far as the clinical scenario and clinical experience is concerned, I think we are very happy with the overall result and long-term result.
I think, sir, I have a question for all of you. I think one thing is about the expansion limit of the stent, and for that, I think I have talked with Mayur bhai and others also. Because I think 4.5, that's the maximum. So how you choose your stent, particularly this abluminal stent in LMCA bifurcation, or where we see a 2.5 and 2.75, we can maximally dilate to 3. That is what has been conveyed to me. 3 to and 3.5 maximally you can go to 4. In fact, Mayur by last time conveyed that 3.5 is maximally, they have a data of around 3.75, and 4 is around 4.5. So many a time we face a situation in provisional part where you see a lady diameter of around, say, 3.5 and LMCA being a larger. Such kind of scenario, what is your experience? You dilate 4 mm stent up to 5 mm balloon, 4 mm stent post dilatation pots up to 5 or 5.5, and you don't see stent fracture. What is your experience? So Prathap Kumar sir, and sir, your experience.
Prathap is going to show us the left main case, so he's perfectly poised to answer this.
I never seen any stent fracture in abluminal stent. Basically, I have used abluminal stent and expand up to 4.5. So I never seen any stent fracture. Actually, I'm just telling you, whenever I have a larger diameter of LMCA, usually I take Onyx as the stent of choice because 4.5 and 5 is available. So that is one situation that I don't take any other stent if the big size, large size LMCA is there. So otherwise, I can take this stent. Most of the time, 4.5 is the maximum size we can get, average size of an LMCA. Sometimes you get 5 and 5.5, where I take Onyx as the choice so far. And
I think Rutvik, yeah.
Now
I think Rutvik, it's a sorry.
Go on,
Kamal,
Kamal.
go ahead.
Yeah,
now
so I think it's a problem of the cobalt chromium platform rather than platinum. I think if you're comparing with a platinum platform, that's the only platform that will allow you to go by 1 mm up. I think if you were to take any other platform, I think it's going to be limited by 0.5, what you're talking about, I think, Rutvik. But Dr. Prathap Kumar and Dr. Dani, your comments on that.
Prathap, you go first.
Basically, the synergy actually can go at nearly 1.25 to 1.5 millimeter more than the normal size, and the same thing for the Onyx. But the point is actually these people are actually, whenever they are using these type of stents, nobody goes up to that pressure. You can say that if 4.5 is taken to 5 or 5.5 is the maximum. The balloon size available, actually I have a 6 millimeter balloon available in my shelf, but many of the people are actually having the maximum size of 5 is the size of balloon available. So you don't have to take only up to 5. Not more than that.
Yeah. So Kamal, it's not platinum or cobalt chromium. It is how the stent is designed. When it expands, the struts and the cell size doesn't get distorted too much without losing the radial strength. That is the key. So the stent design is probably the most important. Yes, you are right in saying that if you compare it with stainless steel, then cobalt chromium and platinum will have much higher chances of getting overexpanded and still sustain the same cell design or similar cell design, giving you good coverage. And as Prathap said, we all go with a 0.5 millimeter overexpansion. Generally, we don't like to give more than 1 millimeter. But yes, we have done from 4 to 5. Believe me, the long-term results are not as good. Even though you may be led to believe that you can do this, 4 to 4.5, we have enough data to show that the results are same. When you overexpand the stent to 0.5 millimeter, it's fine. But beyond that, the data is not there. And in my personal experience, long-term results are not as good. So as Prathap said, Dr. Prathap says, 4 millimeter synergy, you can take to 5, but don't try to do it too often. I would rather prefer taking 4.5 and then take it to 5.
I agree completely.
All right, sir. And
so shall we proceed to the next talk? Dr. Prathap is going to show us a case of exactly about this left main stenting.
Female, a patient came with an unstable angina. Actually, 2012 January, they have done a bypass surgery in 31-year-old female. Off-pump bypass done in Srijitra, Lima to LED done. Cabbage done for LMCA disease of the 95% that time. Now the patient came with a treadmill TMD positive, and they have done antibody is hypokinetic, ejection fraction 50%, admitted for a CAG and ad hoc PCI now. He is a Takayasu disease and actually having anemia. This was an angiogram done. Basically, post CABG came to us with an angiogram. We could not cannulate anything there. I was trying my level best. It is a JL catheter. We could not cannulate. This was a right coronary injection. We could see the filling of left system from the right coronary. Excellent septal collaterals connecting to the left system, but the ostium of LMCA is completely unknown. And the patient had a CT angio done. They also told that it will be difficult total occlusion of the LMCA. So what we did is actually we took a caravan. I took only a JR 3.5. I did not take a left catheter at all because nothing is seen in left. I took a catheter with a caravan You can see the caravel is actually, you can see there is some real connection to the, so I'm searching for the, it's called the surfing of the septal collaterals. This is caravel with Vilrepsi. I'm searching for that. You can see that the wire is going up. This is not a real wire for any CT or retrograde intervention, Vilrepsi, but I took that, that was the first wire I had taken. Now you can see that the wire is moved exactly in the left main, that is in the left system. This is a caravel I pushed along with this curved septal collaterals into the ostium. The wire is actually gone out, and the wire is totally gone out. Where it is actually gone, we don't know. Now, I took a 7 French EBU 3.5 and failed to cannulate. I tried a cyan black wire. I again failed to cannulate. Because the 7 French EBU is not at all sitting anywhere. We really don't know where is the vessel. Now I took a JL 3.5 because I was actually taking, you can see my, even the caravel microcatheter is coming out. But I thought actually I may take, you can see a snare sitting inside the catheter. That is actually one way of taking. I tried a snare, but actually the wire is not going up and I cannot snare it in the root of the aorta. So I tried snaring and I failed. Terribly, I failed. So what I thought is actually I will try an antegrade wire to pass, because my microcatheter created a small channel. You can see a small channel now. So I thought I would try a wire which is basically an XTR wire. You can see the wire actually. I tried a UB3, again antegrade. I failed. But this time I tried again a snare. I tried again, failed. I thought maybe because of the third septal artery, I could not take the wire into the upper part of the aorta. That means to snaring in the upper part. So what I did is actually I tried another septal channel. I took everything out and I took another septal channel. That is more proximal septal channel, so I can have more manipulation of the wire. This is actually another septal channel. Here also I went up easily. Not easily, but I went up.
Same wire?
No, this is actually another wire. It's a cyan black wire. So I took a second septal channel. Again, it came out. But unluckily, I could not manipulate the wire up and to take it. So by the time the movement of the antegrade injection, actually my caravel created a path into the LMCA. You can see a faint channel even from the injection from outside. That means from the antegrade injection. So what I thought is actually with that injection and the keeping, I tried another projection to align for an antegrade entry of Vilrepsi. I just kept the catheter little up and tried an antegrade entry. Now the wire entered easily and the wire is actually gone into some OM branch. So with that one, I just checked it. I was in the OM branch. This is actually an antegrade entry of OM wire, which was actually created a path by the septal. But actually, my aim is actually to reach into LAD. What I decided is actually I will do a balloon dilatation of 2.58 Maverick balloon in the LMCA shaft, so that I create a path for this thing to the LAD. So now I could see something there, but I tried XTR now. This XTR, you can see actually I'm telling a very small fluoroscore I'm showing. So the XTR is actually difficulty with the wire or with the microcatheter in the LAD osteoproximal part. I tried taking the XTR inside. You can see the XTR is going inside. I took a different angle to enter the XTR. This is a wire XTR. I tried with the help of the microcatheter sitting there. I tried to pass the XTR. Now the XTR entered. Once the XTR entered, you can see the wire is inside. I have a connection with this one, an XTR entered. Then a retrograde system I totally removed because I don't want to play around with that. Then I kept a balloon there and a wire inside. So I took a 3x12 Maverick balloon and retrograde system is totally removed. I know that one of the wire is actually in a small branch. Now the next thing is actually I have to do an IVS and see where we are actually truly in the intima or the subintimal space in the osteoproximal part. We identified that it was truly in this intima, but the IVS picture is not like a normal IVS picture of triluminal intimal part and all. We were not sure about what will be the Takayasu. This is actually the image in the osteoproximal part. You can see some vasa vasorum also. A plaque in the osteal LAD is very tight. So this is a distal LMCA. We got a 3.124 millimeter in the distal part, actually the LAD part, which is actually showing a 12.09 is the diameter and 9.5 is the diameter, the lesion length of the LMCA part. So distal reference is really good. No significant disease. This is actually the length. So 12.9 plus 7, it is nearly 20 millimeters. We took a flex storm to cut the lesion very well because in the proximal part we see only 2.5 and distally we have seen 3.24. So we took a flex storm to cut the lesion very well. Then we got one more IVS done. We have seen dilated vasa vasorum and we can see the diameter of the vessel. We took a 3.5 into 26 resolute onyx. You can see some staining in that part. Positioning of the stent in different angle because the ostium is not very clear where in different angles. So we kept the ostium and actually with the measurement which is actually seen from the IVS, we thought it is 9 millimeter outside and then final inflation. We did an IVS again to understand whether the stent is expanded properly or not. We have seen a 3.23 in the distal part. We got a 3.36 actually the part we got in the LMCA distal part and nearly osteal LAD showing 8.28 and LMCA showing 10.76. There was 2 struts was out of the LMCA ostium according to the IVS. So the distal edge is actually no dissection and perfect. And we did a 4 into 8 millimeter balloon dilatation again in the LMCA part. This was the final shot. So the story does not stop here and story continues. A PTCA to LMCTO done on 2/1/21. Actually, the patient had a CABG done in 2012, that is nearly 9 years after. COVID-19 vaccination was done on 25/2021 and patient had an ACS STEMI on 25/5/2021. A normal LV systolic function, ejection fraction 60%. And when we did an LM, the patient was admitted because of the significant ECG finding. We thought we will do an angiogram. This was angiogram. Angiogram showing a significant disease in the LMCA with some staining in the part of the LMCA. So this was the shot. We saw the same shot, but actually we could see a faint filling through the LMCA and we can see a stent is there. So we never bothered about the retrograde. This is the subclavian artery. It's tight stenosis, probably because of Takayasu. So we don't want to do anything on that part. We thought about this time. We took a guide catheter. 7 French we have taken EBU. We actually blindly wired, keeping the catheter outside. You can see I just wired, keeping a fluoro, keeping the wire exactly inside, and I just wired. Luckily the wire went through the stent strut, inside the stent strut. One wire. We did a filter FC wire again. One more wire, I just wanted to take a wire down. This wire I just wanted to take into the circumflex. Initial wire was not going well, so I just withdrawn the wire and I kept the wire through the stent strut This was not. You can see the wire going. I checked it, whether I am in the right position. I taken the wire into the distal part, withdraw the wire, and I went exactly into the, that is actually the stent strap. I gone inside. I confirmed that I am in the vessel, true lumen. Subsequently, I took the wire distally as easily as possible. So 2 wires. I did a 2.75 into 12 Maverick because it is a 3.5 stent. So I had no tension of taking that. I took a 2.75 into 12 millimeter Maverick balloon, dilated very well. I've taken a balloon here. This is actually, I think it is an OCT catheter, I think. We have taken an OCT catheter to take an injection here. The pre-run OCT showing a lady. You can see a lot of neointimal hyperplasia. That is tightest part of the MLA is only 1.93. You can see a lot of intimal hyperplasia throughout the stent. We did a 3 into 10 flextome again. OCT run after that again. This is a bifurcation run. You can see an excellent opening of the circumflex ostium is seen. So we understood that there is no need of doing anything to that, but we kept a balloon there. What we did is actually this time a 4 stent. So we put a 4 into 20 magic touch LMC to LAD and a 2.75 into 12 Maverick in the circumflex together. This is the way I do whenever I want this thing. Then I did a balloon dilatation, 4.5 into 8 Maverick balloon actually as the port we have done. Actually the final angiogram, this is the shot. Then we did an OCT again, final run depth. MSA distal is only 6.78. You can see there is a 108% expansion in the postero-proximal part and a 100% expansion in the proximal part. The mean area is also very good. MSA is 9.7. You can see the area 9.4 in the osteoproximal part. This is a run through. We can see the osteal part is very well seen and the stent is well expanded. We got an area of 8.27 and 7.C2. These are the final shot we have taken, and we have seen the patient, let the patient do very well, and we will have a check angio later. That is what is the presentation. Thank you very much. How to stop the share screen? I already stopped the share.
Yes, sir. The screen sharing is stopped.
Thank you. Thank you very much. Because it is a concept medical program, I thought I'll use a magic touch case. I will show. That is why I selected this case.
Excellent case.
Great case, Prathap. And you did not use OCT first time, right?
No. Actually, that time Sameer basically it was a total equivalency LMCTO. That time taking an injection down will not be as an easy one. Second time I chose, actually I just wanted to understand what is the anatomy in that region and the plaque characteristics. Then it looked like a fibrofatty tissue like, because it is a trachea, so I wanted to understand that how is it, and nobody clearly knows these things. So it is that is why I use the word neointimal hyperplasia. I don't know whether you can term is neoatherosclerosis and all.
Yeah, on IVUS, the first time when you opened the CTO and did the IVUS, the IVUS pictures were not like routine atherosclerosis. It was
Correct.
like a very concentric tissue, whatever it was, that plaque. Didn't look like atherosclerotic with inhomogeneous density. It was pretty homogeneous.
Sameer, one interesting point actually, when this case I presented, Actually, Dr. ABN was asking me, Pratap, why did you choose the second septal collateral to enter inside? So my point is actually, I usually take a snaring in the upper part of the aorta or aortic arch. Here I could not take the wire up because there was, because of the Takayasu, the aorta lumen probably maybe having lot of aberrations, which is not allowing me to push my wire up. So if the wire was there, I could have. Usually we do a snaring in the right brachycephalic part. That will be the easiest part to snare it. Here the snaring is impossible. So, and moreover, the catheter was not cannulating. I was really in trouble. And after doing only for the externalization, I waited for 1 hour in that lab. Till that, it was very simple. I thought I just finished a retrograde very fast. But after crossing the lesion, I was in trouble.
If you look at the left main ostium, sir, on the second event, did you see anything at the proximal part of this, like the ostium of this?
There is some staining was there, which I really don't know what is that. There was some staining is there.
Yes.
Things we really don't know. And I was actually thinking one more stent putting. I decided not to do that. This time I decided, let me see a magic touch and see how is the result. And she is only 31 years now. And 24 years she had undergone a bypass surgery. Now the solutions are very limited, So cutting balloon, I think Sameer will be knowing a lot of Takayasu, carotid and all they are doing. So you people doing a lot of cutting balloon, Sameer?
We do. We do, but here because of the staining, you would be. I agree with you. It would be very difficult to.
I did a cutting balloon here also. One cutting balloon, three cutting balloon I put. I don't know what to do after that. And she was actually having a refractory angina.
See, from George's experience, we know that Takayasu arteritis, if this is Takayasu, then it requires a lot of perseverance. So you keep on dilating the lesions and finally they stop re-stenosing. So 1, 2, 3, it's who blinks first. It is that kind of a situation. So with aortoarteritis in other vessels, I'm not talking about coronaries, but what George Joseph's experience is, and we have learned that way, and I can corroborate that way, that any vessel of Takayasu restenosis without hesitation, without any frustration, you go in, redilate, keep on redilating every time it restenoses, reassure your patient, and finally 2, 3, 4 times, and then those vessels stop restenosing. So hopefully in coronary same thing will happen, and maybe this time the vessel will stay open.
Yeah.
Let us hope.
So one question: whether the disease was active or not?
I'm sorry. Is the patient on mycophenolate?
Yeah.
Is the patient?
Is the patient on any immunosuppressant, mycophenolate? Or,
She is on steroid. Regularly on steroid, and she's actually, her ESR is maintained at, I think, 10 or 12 only. She's never gone into that. Actually, after I saw her, well, she's on steroid regularly, Visalon 5 mg daily, and she's maintained everything and no other symptoms at all. She's an engineer by profession, unmarried, but severe symptoms, So we have to do something. And actually, this was actually in Srijitra, people told that, okay, CTO, LMC, so you go to Dr. Prathap. That is why the patient came to me.
Lima was a pedicle graft? Lima was a pedicle or free graft?
Lima was free graft. I don't know what graft. Actually, Lima to LAD is connected. So LAD, but because of the subclavian disease, I think that is gone.
That is gone.
Severe chest pain. And otherwise, we have to we can tell them that have a venous graft connecting from another graft can be connected.
He has very limited options.
But I I don't know how Magic Touch will behave with this thing. Let us see. I was thinking about that only.
We all don't know how these aorta arteries behave, but in your case, already the bypass graft option has been exhausted, and we have left with the percutaneous intervention. But definitely, this is a good case, and it will. We don't know how this aorta arteries behave differently with atherosclerosis because number of cases and our follow-up experience are the less. But we'll still mix up the both atherosclerosis treatment is dual antiplatelet and statin, and also the add on the tachysis arthritis immunosuppression. Both we continue. But we follow for the renal. Yeah, we don't have coronary. We have cases, but they're not large, one or two only.
Okay. Okay.
An excellent case demonstration for the retrograde as your master always feel that the good patient in the best, and that's why she got the good result also.
I don't know whether it is a good result because outcome is actually within 6 months. I have to do one more procedure, for her.
About once
It is probably because
is
of the inflammatory condition. Yeah.
Yeah.
So I was just thinking adding a methotrexate here because a lot of people, rheumatologists, they prefer to give. So methotrexate if added to low dose steroid, probably, I don't know, we can explore with the rheumatologist. So methotrexate once a week therapy with dual antiplatelet with statin steroids.
Rutvik, Vellore people, CMC has very large experience and they have very large series of treating aortic arthritis. And they invariably prefer mycophenolate over steroids or methotrexate. So I do not know for sure, but it seems that rather than steroids, mycophenolate works better in these cases, but wouldn't know.
Yeah, true.
We move on to the next one. That is from you only, Dr. Rutvik. You are going to present the next.
Yeah, fine.
Please go ahead.
Yeah. Good evening and thank you, Concept Medical, and thank you, Krishad, thank you, Jay Bhai and all. It's very heartening to see known people, teachers, colleagues, and senior around. And we have seen excellent demonstration of CTO intervention by Prathap Kumar sir. And we all know he's a master, he's a busy guy. I think after an hour, he's going to address one more complex intervention. Tomorrow, 2 days is full of his Medtrina CTO. So CTO intervention, what?
1 minute, Rutvik. Actually, I have to go for the calcium talk. It is 8:15. I was thinking it will be finished. But sorry, I will be, if that, after that finishing, I'll just come back again. Can I just go and come back?
Sure.
Sure.
I will also have to do the similar thing. Maybe go and come back. Something was planned. But anyway, go ahead, Rutvik. We are here right now. You're not audible, Rutvik.
Now, Mayur bhai, am I audible?
Yes, now you are audible.
Now you are audible.
Rutvik, what you can do is you can switch off the video.
Yeah.
Because there's a little bit of lag.
Yeah, fine. So now the audio video, I suppose it's working.
Yes, sir.
Yeah. So this case is of ACS and venous intervention. So my case is around case of a 69-year-old female diabetic hypertensive. She had acute coronary syndrome with a chest pain of 7 hours duration. ECG had shown ST elevation in V1 to V4. Ejection fraction was 35, and the CABG was done in 2008 with the 2 grafts. Both grafts were the venous graft, And the last follow-up report it was suggestive of ejection fraction of 55 with almost normal ECG. So considering the symptom and the new onset of acute coronary syndrome, she was referred for further management, and we took her for the intervention. The ECG showed clearly ST elevation in V1 to V4. The troponin is high. His right coronary was a CTO mid-segment. Left also CTO with the circ showing 80% lesion. This was the condition of his venous graft to LAD, which was totally occluded and full of thrombus. We tried various views to find out other grafts are present or not. This was the LAD graft, and RCA graft was almost totally occluded, and we can see a stump here that RCA graft was non-existing. So do we have evidence-based guidelines for management of this kind of patients? This was an ACS and venous graft with a lot of thrombotic burden, and by experience we all know that SVG intervention remains susceptible to very high rates of periprocedural MI, and we are all worried about the no propylomela, and that generally leads to a more morbidity and mortality. The SVG intervention is responsible for around 5 to 8% of the cases, and in fact in horizon MI it was around 5% of the all ACS consist of a venous graft acute coronary interventions. Retrospective data has confirmed that this area remains particularly a very high risk of intervention with a very high mortality at 30 days and 1 year. Data is limited because many of the trials excluded this venous graft intervention, and with whatever data and literature is available, it is foreseeable that the robust evidence-based guidelines will ever come to manage such kind of situations. Now coming to embolic protection device, we all are aware that the material which is generally seen in the venous grafts has a cottage cheese consistency, and EPD has been a class 1 indication. But the EPD indication came from the one trial which was released in 2003 and 4, and which is a safer study. In fact, the ESC recently in 2018 has downgraded the indication of EPDs in venous graft intervention. In fact, a study by Mamez et al. In a multivariate analysis, he also showed that there is no great benefit as far as the acute venous interventions were concerned. GP2B3 inhibitors have no role. In fact, the intragraft vasodilators were found to be only agent which are useful as far as the prevention of no flow and slow flow phenomena is concerned. So what we planned here that we'll take a pharmaco-invasive approach in the same setting. So we parked the wire because there is no, generally the filters are not available, and here there was no space to park a filter. So we took this hydrophilic wire, and we planned to give a thrombolytic agent which is actylase. The initial plan was to give maximum 10 mg. So 5 mg, 2 infusions were given slowly over 5 minutes, and then look at the response, what happens. And meanwhile, we plan to give a lot of adenosine to prevent a slow flow or no flow phenomena. So we parked the wire, thrombuster, with the use of thrombuster, we tried to remove the thrombus as far as possible. Then with the same thrombuster, we injected 5 mg of injection actylase. We waited for 10 minutes. There was some restoration of the flow and some resolution of thrombus in the venous graft. 2.5 mg of second dose was given, considering a age and a fear of bleeding. We give a lot of vasodilators. And after this, we had a good flow in the venous grafts as well as the filling of the native vessels, with all the septals and diagonals were visible. And we use abluminostat. This is one of the cases which are almost included in the enable registry. We use 4/28 stand inflated at 12 atmospheric pressure. There was some under expansion noted, but we thought we should not post dilate, and many of the experts, they do recommend that aggressive post dilation will lead to more complication. So if the results are acceptable, you just leave it. Post-stenting, we had a M3 flow both in the graft as well as in the LAD, and both the septals diagonals were filling. There was a good flush being noted. This was the final result which we have. Patient did well and discharged. She is doing well up till now. She is in my follow-up. This was the second case that we attempted in a venous graft of SVG to RCA. This was inferior wall MI, post bypass. Almost 4 grafts were done. Complete flush occlusion of the venous graft. The wire, remove the thrombus, whatever I can remove. Injection Actilize was given 5 mg. So that a reasonable flow achieved. And then abluminous implanted. No complication noted. Patient is doing well. And this was also a third case, which was more of non-ST elevation MI with SVG to OM graft stenosis with haziness being noted at the proximal part. Again, we use the same protocol. Plan was to give a maximum dose of 10 mg. I think something has happened. I'm not able to move the slides. Technical team, anyone can help because I'm not able to move the slides from my end.
Sir,
It is stuck here.
the network issue, because your voice is clearly audible and I cannot control your system. So as far as the form is there, it is pretty clear.
Wait. If you exit the presentation and
Yeah.
if you have AVI files
fine.
in your computer, you can play from
Yeah,
there.
now it is moving. Yeah, fine. Now it has moved. So this was the result again. Abluminous stent, implanted, and we had a reasonable flow. So in all the 3 venous graft intervention, no filter was used. It was all venous graft, ACS scenario, pull-up thrombotic burden, and we were able to manage with the pharmacoinvasive part. Thrombolytic agents were given with with the thrombus aspiration device. So the take home, I think, is that we all are aware that the total arterial revascularization is a very popular concept, but there are few conditions where surgeons are not able to perform this job. Many conditions they still use a venous graft. Older patients, the previous surgeon had used venous graft to LAD and RCA they are commonly using. So they are almost prone to develop a degeneration. The attrition rate is around 10% per year. So almost at 5 years, 50% of the grafts degenerate. So these are a challenging subset, and in a stable patient, of course, the US indication still suggests the usage of filter, but in acute thrombotic occlusions where the filters are not available in the inventory, there is no space to park this filter. The tricky situations are there, and I found this technique very reasonable. In fact, I published this paper. Now I have almost 6 to 7 patients, I would say, where I use the same technique. Thrombolytic agent maximum I have given is 15 mg. All the patients were having acute coronary syndrome with first 12 hours duration, and I found it that the no flow phenomena, the fear of no flow and other complications were reasonably less with this approach. These first 3 cases I used abluminous stat, and with that also slow flow and other components were not noted. So I end my session here or talk here, and for the expert opinion, teachers and colleagues, and take questions if at all it is there.
Excellent cases, Rutvik. Excellent. Anand.
Actually, Tarun.
Yeah, Rutvik, excellent cases. Just due to your voice problem, how much thrombolytic agent you give? 5 milligram, 10 milligram Actilize?
Yeah, plan was to give maximum 15 mg. In the first old lady, I gave 7.5 mg. My plan was to give maximum 10 mg because she was loaded outside, and then it was a clopidogrel. Then in ER she was again given a Brilinta, so I thought she will bleed, and that is why with 7.5 mg I had a good result. But in rest of the cases, second case was a young guy, relatively 55-year-old man. I used 10 mg and I had a flow. The third case again I used 10 mg. It was a case where ST elevations were not there. It was more of a ST depression. So TROP positive non-ST elevation with the OM graft intervention. For next four cases, all are acute ST elevation cases, and I have used maximum 15 mg.
But how much heparin you will give?
Actually,
This is because
Tarun,
TPA thrombolytic therapy you upfront decide, you decide on the table. Then you have to modify your heparin regimen. So how much heparin you give or keep, how much ACT you will keep?
Yeah, so here when you know by history that it has the venous graft intervention is anticipated, the strategy is that you start with the 5,000 heparin and measure the ACT. The ACT is kept usually is around 250 to 300 when you plan to give any sort of thrombolytic agent. So that was a routine part. Anything above that, I thought, because in this case the ACT, first case the ACT, I fear that it's going to be high and the patient will bleed. So anything more than 300, my plan is to give only 5 to 7.5 mg. So up till now in 7 cases, I followed the same strategy. I have not encountered any case where people have loaded and given Clexane, and by the time I have taken a patient for intervention and the ACT was very high. So that scenario I have not faced. So what I did in first my 7 cases, that I generally talk to them whenever they call me that don't load anything. I'll be loading in ER, and I'll give 5,000 heparin for the intervention.
So I extrapolated tips of thrombolytic in thrombolytic because in osteal LAD, while you are treating the osteal LAD in subacute phase, the organized thrombolytic complex. So there are in circumference. So there are chances. So in one case, I given the intracoronary. So the plant intracoronary Actilase 10 mg was given, and patient behaved very well, and thrombus clearance also good. The purpose of giving the thrombolytic because heavy thrombus burden in the osteal LAD with second day of MI. He was thrombolized and residual thrombus was there. To prevent the migration, I also use the thrombolytic therapy. And ACT also keep the 250 to 300. Jay and Tarun.
Yeah, I witnessed this case. Anand Bhai did it very recently. Like they've, unfortunately, I did the same case, but I've not used intracoronary thrombolytic agent, and patient had a very bad slow flow phenomenon after using a multiple, even after usage of injectable abciximab, the patient was not able to achieve a good distal flow. So in that particular category of patient where you are using any intervention in the osteal LAD, it is better to go for a thrombolytic agent as compared to even a GP2B3 inhibitor.
In fact, Jay Bhai, whenever you give it a native vessel, what? Yes, sir. Anand Bhai.
Yeah, Rutvik.
In native vessel, whenever you give, make sure that you have a defibrillated standby, because in that scenario, there are fair chances that patient will fibrillate. So in acute coronary cases with a heavy thrombus burden and you are planning to give, fibrillations were more noted in native coronaries compared with venous graft. So venous graft I have not seen, but when I gave it in scenarios in LADs with heavy thrombus burden, most of the time patient fibrillates and then the recanalization occurs.
Okay. Good observation.
I think these are excellent case
In my case,
all the attendees,
next.
I think Anand Bhai and Rutvik Bhai and Jay Bhai have shared. So we take home some messages for everybody's learnings, that good thrombosuctions in venous grafts, no filter, and proper dosage of thrombolytic therapy, that is to be graduated 5 milligram followed by another 5 milligram if there is no response. That's right, Rutvik Bhai?
Yes.
Perfect.
And another way of
So good evening, all. So without wasting much of the time, I'm presenting a relatively, I would say, a non or rather a less challenging case. But the challenge was to find the culprit artery in this particular case. The 53-year-old male, diabetic, non-hypertensive, presented with an acute infeval MI, non-thrombolized. He is a smoker, non-alcoholic. His routine investigations, they were normal. Troponin was positive. ST elevation was being seen in the inferior leads with reciprocal changes. The echocardiography was showing ejection fraction of 45% with basal and posterolateral wall hypokinesia. On the right panel, you can see that the patient is having elevation not only in the inferior leads but in the anterior or the septal leads as well. And in the right-sided on the panel A, you can see that it's a right-sided lead where you will be able to see the elevation in the right-sided RV3 and RV4 leads as well. And this was the angiographic picture of that particular patient. You can see that the amount of ectasia in the left coronary system is tremendous, and this was epicranial and areocaudal view, which is showing a left main LAD and the circumflex. On the other panel on the right coronary system, you will be able to see that. Hello.
Yeah, Jay,
Yes, sir,
you are audible.
We can hear you.
Yeah,
You're
go.
audible, sir.
But but I mean the slide which I was showing, it has suddenly disappeared.
No, it's
So stop sharing your webcam here. So only the slide
yeah,
will
yeah.
be
So
possible.
I think, are you able to see the slides now?
yes.
Yeah, it's running. We can see.
Yes, sir, it's running.
Yeah. Okay. Fine. Okay, fine. So in the upper panel, you can see that the right coronary artery system, even after taking RO and the LO view with the help of pictal catheter, you are not able to see the ostium of the right coronary artery. And here we all know that patient is having acute infeval MI. So we are in search of right coronary artery because the ultimate intervention is going to be required in that particular vessel. The thing is that in such type of scenario, when you are dealing with acute infeval MI and a thrombotic occlusion of the artery, and if you are not able to find out the artery, then it is better to just stabilize the patient, and that is what we have done. We have put him on a GP2B3 inhibitor and get his CT coronary angiography done, because we were not sure whether the patient is having any anomalous origin of the right coronary artery or not, and that was being observed or seen in CT angiography. Here in the left panel, you can see that the right coronary artery is arising anomalously and it is being occluded right from the proximal part. The LAD is looking pretty okay with a ectatic vessel in the proximal part of the left anterior descending artery. And we got the patient again into the cath lab, and the RCA was being engaged with the help of 3O-GL catheter. You can see that after the GP2B3 inhibitor upstream with the help of JL3, now the artery is being visualized. You can see that it is an anomalous origin of the right coronary artery. Now the main problem was to engage this particular catheter at the ostium of the right coronary artery. After multiple try, what we have done is that we have kept a distal end of the O35 wire, which is a hard wire, in the tertiary curve of the catheter JL3, so that it has given a proper support on the opposite side or the opposite wall of the cusp. And from the other side, we have passed a run through wire into the right coronary artery system, and through that we could at least make a proper engagement or a coaxial engagement of the JL3 into the right coronary system. And after that, we have used a thrombus suction catheter multiple times. In the panel 4, you can see that in the levo phase of the injection, the left coronary artery system and the right coronary artery system both are being visualized there. So in that case, the right coronary system is being raised from the left coronary cusp. After using a proper thrombus suction for multiple times, and after doing a daughtering, we could able to at least achieve some lumen in the right coronary system. And then the vessel was, and the vascular bed was being prepared. with the help of multiple balloon, and then 2.5 milligram, 2.5 by 40 mm of abluminous stent was being deployed in the distal part, and in the proximal part 3 by 40 millimeter of drug-eluting stent, which is abluminous, which was being deployed, and this was being further post dilated with the help of 3 millimeter balloon right from the proximal part to the distal part, and the overlapping segment was again being dilated, and this was the angiographic picture of the right coronary artery in the epicranial projection and in the LO projection. You can see that the anomalous origin of the right coronary artery was being visualized in this particular patient, and this was the post-procedure ECG, which has shown a complete isoelectric ST resolution with a significant reduction in the level of the ST segment after the intervention. So the take-home message was that in a case of acute MI, anomalous coronary artery is always a challenge. It is highly complex intervention. We must know the proper or a complete knowledge regarding the hardware selection in such type of intervention. There are different kinds of catheter which are being utilized in such kind of vessels. They are employed right or left, extra backup, Judkin, multi-purpose. But in this case, as RCA was arising from the left coronary cusp, and it was very near to the ostium of the left coronary, left main, we opted a Judkin left guiding catheter with the smaller curve. And in some of the other cases, you can always have a left Judkin 4 or maybe a right Emperor's 2, AR2. You can always utilize those catheter to have a successful outcome for this type of cases. I'm having such type of cases, like we have done around 5 or 6 cases with the help of JL3 only. The main area where we find a challenge is that when we have a drop of aortic pressure, that is possible when you are having acute prolapse in the coronary cusp, which is leading to an acute AR. So when you look at the hemodynamic tracing of the patient, you will be seeing like a damping pressure changes. What you are seeing when you are engaging the guiding catheter at the level of the left main, similar sort of waveform will be utilized or will be seen on an hemodynamic pressure monitoring system. But it is because of the fallback of that catheter, which is producing an acute cusp prolapse leading to an acute AR, producing a reduction in the diastolic pressure. Sometimes this can lead to a relative ischemia because the left main or the diastolic perfusion of the coronary artery is getting hampered. And in some of the cases, if the catheter is very large, it might obstruct the origin of the left main. And in those category of patients, you might see some changes or ECG changes or ST deviation on a monitoring screen. So these are the two important things which we must learn and utilize when we are doing such type of anomalous or artery origin angioplasty. So thank you so much for the quiet listening. Thank you. Hello.
Good demonstration of anomalous RCA that is arising from the left curve. So as you correctly mentioned that we can use the JL3, but while engaging the JL3, we may require O3 pair sometimes to sit properly. Yeah, initial part. Otherwise, we can use the AR2 or Embolic other guide to engage the RCA. But definitely, when acute MI setting and the anomalous origin, if the patient came in the daytime, that is good, but in midnight, difficult to manage the reflexes and find the vessel. So it
This was being done at 2 o'clock in the night.
Yeah, it is up to our luck at what time we are encountering such anomalous artery. How much consciously we are while doing the case.
True. Very true.
That was a very excellent demonstration, and you rightly mentioned, so middle of the night, if you keep on exchanging guides and diagnostics, it is very frustrating for the operator and for the nurse. So these are very challenging subset when they come out of the normal hours. In radials, I had one experience, and just like to say, so in radial, if you are doing, in one case, I was using a routine Tiger catheter, and with the Tiger I was able to hook that. When I tried with the guiding, I was not able to hook, so I again took the same catheter, parked a double length wire, removed the diagnostic catheter, and with the JL with O35 wire I took JL3, and both the wires, this O14 and O35 taken together in the JL3 guide, and then I was able to hook. And in one of the case I tried to hook because I had a sample which is available, is a Tiger guiding catheter. So take catheter, it was almost like if you press it in the left cusp, and the primary curve will sometimes go very close to the catheter, and if you just try a surfing or passing a wire, your wire will go, and then probably with the help of guide liner or guide extension you can push the device inside the vessel. They're very tricky subsets, and you need a lot of I think hardware. So nicely demonstrated case.
Thank you. Thank you.
From the attendees, Dr. Naga Srinivas has a question. Why not IV thrombolysis when you couldn't engage the coronary artery?
Why not intravenous thrombolysis?
Why
Yeah,
not
because,
IV? Yeah,
because the
intravenous
problem was,
thrombolysis when you cannot. Yeah.
because the patient was already been loaded with ticagrelor 90 milligram on top of 600 milligram of clopidogrel. So I was little bit frightened in giving thrombolytic agent in such type of scenario where you do not know that if the patient bleeds, then again we will be in soup.
And you have vascular puncture, and you have vascular puncture is already there. So things
Exactly.
becomes very tricky.
Thank you, sir. I hope if there are no more questions, we can conclude the session with your permission.
Absolutely. Yeah. I think you can ask Sir Sameer sir or if he's there.
Sameer sir has just left.
Okay, no problem.
So
I think we can ask
Dr.
Anand.
Anand sir and Tarun sir. Yeah. Thanks for giving your valuable time for this nice, wonderful learning session. And we hope to see you for the next event with Krish Academia on 25th of September, which we'll be having purely on the coronary usage of drug-coated balloon magic touch we have. Thank you once again, all the attendees and the presenters and the moderators.
Thank you. Good night.
Thank you.
Thank you very much. Thank you.
Thank you so much, sir.
Thank you, Anand bhai.
Thank you, Tarun bhai.